Good afternoon, everyone. For those of you who may not know me, my name is Lisa Ferguson, and I'm a program manager in the Department of Learning Health Sciences and a member of the LHS Collaboratory Planning Committee. On behalf of the entire committee, I want to thank you for joining us today at our first live stream of the LHS Collaboratory Seminar Series event, Mobilizing Computable Biomedical Knowledge here at Michigan Medicine. For those who may be joining a collaboratory event for the first time today, welcome. The LHS Collaboratory is a pan-university community that brings together faculty, staff, students, and others who are interested in topics related to the learning health systems. For those who regularly attend these events, you are used to being together with your colleagues every month to network, enjoy lunch, and of course, hear interesting speakers. We wanted to be sure to continue this community connection and camaraderie, especially now. While I will be moderating today's session, I bring to you tidings from everyone on the Collaboratory Planning Committee, our co-chairs, Chuck Friedman and Doug Van Houweling, as well as Kathy Karagiannis, who handles all of the communications and logistics for these events. They all send their wishes that everyone is safe and well. Thank you to everyone who helped bring today's event to fruition. Our two presenters, Dr. Lanham and Dr. Singh, Kathy, Chuck, Doug, and Murphy, our Chief Department Administrator, and of course our DLHS Communications team and Russell Video. Just a few brief announcements before we begin today's session. There are two collaboratory events that are being rescheduled. So one was Dr. Stefan Bose coming over from Switzerland to talk to us about the Swiss Learning Health System. And then we also had a panel presentation that we were going to have where we had leaders from other health systems come in to discuss with us what they're doing at their organizations related to LHSs. So for now, those have been postponed. We haven't decided if we're going to do other events this season yet. We aren't sure, so please keep checking our website for any future events. For today's session, we're going to do some opening remarks here. I'll handle that. I'm going to moderate the session today. Then we're going to have Michael Lanham talk about electronic health record EHR integration for learning health systems, followed by Karandeep Singh talking about machine learning infrastructure for learning health systems. We will have a Q&A session at the end, so at the very end. So as you're listening to these presentations today, please take advantage of the Q&A tab on the live stream. So you can enter your questions there, and then at the end, we'll select some of those questions and present those to the speakers today. And we'll be finished today at 1:30, and during the live stream, if you have to leave early or if you have technical difficulties or anything that prevents you from finishing the program, it will be available via video on our website. In terms of today's session, I'm just going to say a couple of things before we get started and put a little framework or background around today's speaker presentations. Chuck and Doug thought maybe based on my background and experience, this would be a good session for me to moderate. So I'm going to make a few introductory remarks. In order to do that, I have to give you a little bit about my personal and professional background. Prior to joining the Department of Learning Health Sciences here at U of M, I was in healthcare IT for 29 years. For the majority of the time, I worked for healthcare IT vendors, Shared Medical Systems, Siemens Health Services, and then Cerner Corporation. And I also worked at hospitals. So I worked in the IT department at a couple of different hospitals. So I have that experience as well. And today, what I'm going to do is talk briefly about the long-standing, complex, and challenging environment of healthcare IT when everything is going smoothly, just how complex it is. Then I'm going to talk a little bit about the research that's being done here in order to get knowledge into practice quicker, and then how those two things come together. So first I want to talk about the constantly evolving complex IT department, or I'm sorry, IT environment. We, as health systems and hospitals again, even when everything is going smoothly, they have this complex environment they have to navigate. There's constant technology changes. When I first started my career in IT, there was tons of paper. Obviously, we've had a lot of technological advancements since then, but these hospitals and health systems have to constantly adapt to changing technology. They have to adapt to and comply with regulatory requirements, so claim and payer requirements, meaningful use, HIPAA, just a few things that happens in the regulatory environment that they have to contend with. They're constantly looking at improving provider and clinical workflows. And, then there's the whole operations pieces, scheduling, payroll, financials, bed management. And then on top of that, there's also things that have occurred over the years in terms of trends and just culture in IT. At one point, hospitals were doing their own in-house, if they could afford it, creating their own applications in-house. There was a time when best of breed was the thing to do. So everybody went out if they could and bought the best lab system, the best pharmacy system, the best whatever, and cobbled them all together. So again, even in the best of times, this healthcare IT environment is just very complex, and hospitals, healthcare systems, payers, the government, just a lot of actors involved in this. After I left Cerner, I came here to the University of Michigan and joined the Learning Health System research here in the Department of Learning Health Sciences, and learned all about learning health systems, the focus on mobilizing computable biomedical knowledge, and trying to improve health through research and bringing this knowledge learned through research into practice sooner. And once again, just even in the research environment, it requires a lot of people with different expertise, perspectives on the problem of interest or the problem of study. And, there's just this whole, another set of, or another group of actors and players and levels of governance, levels of perspectives that just have to be, taken into account from a research perspective. So then it brings us to the point where we're trying to combine this complex healthcare IT environment, which is in place for just normal operations, all the policies, people that are involved in that, and then bringing forth all of the research where we're trying to improve health through this research. And we're trying to, combine research and IT. There's several different things that I've been involved with here related to this. We had the PCORNet project where we were establishing U of M as a node on the PCORNet research network. That involved a whole set of governance related to internally here at U of M, at the regional network, at the national network. And then, we had to tap into the existing healthcare IT structure here locally in order to get all this work done. We have people here that are working on risk prediction models and coming up with these models, which again, we want to get them into the production IT environment in order to bring this research to practice sooner. So with that, I want folks to kind of think about that context as you listen to the speakers today. And I'm going to turn it over to Dr. Michael Lanham, our first speaker for today. And Dr. Lanham completed his medical school residency and fellowship training in OBGYN and reproductive endocrinology and infertility here at U of M. He is board certified in clinical informatics, and his academic interests include the interface and interaction of usability, information systems, quality care, and clinician burnout. He serves as the Associate Chief Medical Information Officer for Provider Builders and Custom Workflows Programming at Michigan Medicine. Nationally, he serves as a reviewer for the International Journal of Obstetrics and Gynecology, as the chair for the EPIC REI Steering Board, and as a member of the ASRM Technology Committee. He has invented and developed software to assist infertility patients with their medication inventory and administration management during complex fertility treatment, which is currently being studied in a multi-site trial. So Dr. Lanham, I'm going to turn things over to you, and thank you for being here today.
Hi, everybody. Thank you, Lisa, for the introduction. As I was preparing for this talk, as we discussed in putting this particular presentation together, trying to get folks a feel for what integration into an EHR could look like, and also some non-integration changes in the EHR. I reflected on how I got to this point and the work that I do as one of the Associate Chief Medical Information Officers, and just want to give a little bit of my background like you did, Lisa. I did all of my training here as a physician, but have a background in computer programming as well, and so have done projects to help with things like that over time. You mentioned a homegrown system for an electronic health record, and Michigan had one at the time that I was a resident, so I was able to help directly in some of the programming with that. And then as we installed Epic back in 2012, became involved, and as faculty was able to get the ability to then directly program in the system. One of the things that led me to is that I also part-time have a consulting company where I do custom development, configuration, some interface work for Epic customers, which is my disclosure for this talk. As far as learning objectives for this particular talk go, I would like folks to be able to have a general idea of what integration with an electronic health record could mean. I'll talk through some real-life examples of integration goals, why we would want to integrate with an electronic health record system with other software or other technology, which you've already mentioned some options for support of learning health systems within that EHR ecosystem, and then some real-life considerations when trying to do that. Specifically, how do changes get made in an EHR? How does this affect integrations? What I'm not going to cover are what are all the technology options for integrating with an EHR, because I think understanding how you even ask the question of how do we do this integration, and all of the social aspects that you've already begun to touch on, Lisa, are as important as the technology itself. So that's where we're going to start. So starting with what can integration with an EHR mean, and what are some specific examples. The what piece are essentially some interaction between a couple electronic resources that otherwise can function independently. They have work they can do on their own, but putting them together may have some benefit or add some functionality. Why might you do that? It can simplify a workflow. So instead of having to take information and put it into one system and then look at how that, some sort of score, then take that score and put it into a different system, you can just do it in one place. I just mentioned an example where you actually might be transcribing information from one system to another. And in that setting, there's always the risk of transcription error. Even things as simple as a patient's name, if you have to keep typing it in multiple places rather than relying on one source of truth via some sort of integration, you risk actually a transcription error there with your date of birth, for example. Anytime you have logic with clinical decision support, so should this patient be on this particular medication if they have this particular allergy, if you have to keep recreating that logic in different outside systems instead of depending on one source of truth, then there's always the chance that one of the places where the logic needs to be updated doesn't get updated. For a timely example, for example, as the COVID-19 screening recommendations change, at even specifically University of Michigan, there are multiple places where that has to be touched. And that's just in the EPIC system that we have. And so adding an integration on top of that means potentially touching that logic even more. And then improved visualization, I'll give a very specific example of that, but essentially instead of having to click through to multiple systems or even log into multiple systems, it allows a user to see what they need to see at one point, so improves the usability piece. There are a lot of words on this slide, and I'm going to show these examples in later slides as well. But for example, with the what, you could have an ultrasound machine that is receiving and sending information to improve the usability from the end user's perspective of not having to go to the ultrasound machine to see images, for example. With a pulse oximeter, which measures the oxygenation of people's blood, instead of having to look at the oximeter and then write that information down either on paper or in the electronic health record, it can be interfaced so the information goes directly into the EHR. Similarly, it could even send an alert if it's under a particular threshold. The why, mentioned earlier, you could avoid having to have multiple applications with multiple sign-ons. So you could use single sign-on in order to allow folks to get to information without having to sign in again. The demographic information, so not having to retype information such as address, date of birth, avoiding those transcription errors and confirming that you always know that it's true because you confirm what the source of truth is. I'll show the visualization example in a moment. And potentially, if depending on the electronic health record, there may be computing functionality that simply doesn't exist in one system, but it is already built in another system. And so if you're able to interface the discrete pieces of information, such as age, particular diagnoses, and current medications into another system, you could get back a risk score or what the recommendation for next diagnostic test is. And finally, and this is a little bit specific to Epic, but they are the software that their server software, is based in a programming language called Cache or MUMPS, which is not particularly familiar to most people. It is what I do my consulting work in. But you would have to learn that language to write some of the logic if you wanted to do add some real bells and whistles. And integrating allows folks to write their software in the language they're familiar with, that they know how to test, and then integrate in with the system to avoid having to learn a different language. So go specifically through the ultrasound machine example, the electronic health record and this is an example, but the integration points can go many different directions. So I'm just trying to give a couple of real life examples of how an integration might work. The electronic health record can work without any ultrasound anywhere. You could imagine that perhaps someone could do an ultrasound and then type all of the results into the electronic health record. The ultrasound itself would know nothing about the patient per se, but the patient could still be cared for. However, instead of having to type the patient's information into the ultrasound machine or what order has been written, you could have an interface, and that does exist, that takes the patient information and sends it to a set of ultrasound machines so that the ultrasonographer goes in, they simply find the patient, they can see what's meant to be done, and they can do their work without having to do that transcription of demographic information. Similarly, the ultrasound machine can then send those images to a picture archiving communication system or abbreviated PACS. The ultrasound machine itself can store the images, and so if as a clinician I want to go see images, I can just go back to the ultrasound machine. In reality, for example, in the infertility clinic at the University of Michigan, we have 4 different ultrasound machines, so I'd actually have to know which ultrasound machine a patient had the study on a particular day, which is not particularly convenient. So instead, I can go to the PACS system and pull up the images. And then there's an additional integration point that instead of logging into a separate system, the PACS system, and looking at the images, I can pull up those images by simply going to the patient's chart in the electronic health record or Epic, finding a hyperlink that then uses that single sign-on technology to get me to the images without me having to sign on separately. So you could add extra arrows. There are extra arrows in the way that it actually works here, going back and forth, but this is one example and a couple different places of are examples of the why, and both the why and the what of an integration. Pulse oximetry, to go through that example, if you sat in the room while the pulse oximeter was in the patient, you could see what the oxygen saturation is over time. However, most people have other things to do besides just stare at the pulse oximeter. And so if you've ever been in a room like this, you can actually hear that the sound changes over time. You can set a different threshold so that you actually get an alert. So if you're, again, sitting in the room but not staring at the screen, you can get alerts as those number changes. Or the information can go into the electronic health record so that you don't have to look at the number every 5 minutes and write it on a piece of paper or transcribe it to the electronic health record. And similarly, there can be an integration with a paging system. This could go via the EHR, or it could be a standalone integration where there's a threshold, and if it goes below a particular threshold, it could go to a pager or a text. So again, you could write the arrows in many different directions, but just another example of what and why. The single sign-on is something that most folks would be familiar with, because anytime you're going somewhere and it says continue with your Facebook login or continue with your Google login instead of creating an additional new login for an application or a web app, that's the same technology that we're talking about. So it basically uses your credentials for one system to let you into the other system. Similar thing with Epic. There is technology where you can use the Epic login, both as a patient and as a provider, to get into other systems once it's set up correctly. And then this is the visibility example that I wanted to give. So from left to right, this is an infertility example, and it is pertinent to me because of my training, pertinent to me because I developed it and coded it, but also it allowed us to finally get rid of paper after our electronic health record implementation. So just a little history. We went live with Epic in 2012 institutionally, but at the University of Michigan Fertility Clinic, all the information you see on the screen, which are follicle measurements. So follicles are small cysts in an ovary that grow when people are undergoing fertility treatment or not. And we need to look at those measurements to know what to do with the doses of fertility medications. The E2 column stands for estradiol. That is the hormone that changes over time in response to the fertility medications. And then the final 3 columns are the medications that the patient are taking, the specific doses. And although in this patient they're taking the same doses many days in a row, that is not always the case. What we were doing from 2012 to 2015 was actually still transcribing all this information from the ultrasound machine, the lab interface system, the patient messages we were sending onto a piece of paper so that we could visualize it, because the change over time is very important. Any one of those pieces of information by itself is not enough for us to make a clinical decision. And so in this particular case, the interface from the ultrasound machine, the lab interface system, the medication management software, all into one visualization was very important for us to be able to retire the piece of paper. And from a workflow perspective, it finally worked in a way that we could do that. In the example of externalizing computation or decision support, there is one particular technology that exists out there called clinical decision support hooks, or CDS hooks. And this is one of those situations where an integration may allow you to do work once and then reuse it in multiple systems, potentially in multiple electronic health records. Because the idea is that when the hook is created and the logic is created, that only happens once, and then you can hook it up to any number of Epic systems or Cerner systems, for example, and the provider would get a similar experience at all of those places. And that's the idea. So to just walk through the workflow here, if a provider were to order Toprol, the EHR would send out a call to the CDS service, get a little more information about the patient, and then send some information back to the provider, such as what the patient pays, what in the case of this particular patient, the recommendation would actually be to use hydrochlorothiazide instead, or link to some external application for managing hypertension in general to get even more detail. So I'll talk about FHIR in just a minute here. This is based on FHIR. The idea being that integration can keep you from having to redevelop the same logic in an EHR time and time again, so that if I'm a patient and I go to St. Joe's in Ann Arbor, for example, and their Epic system hasn't put this logic in place yet, and then I go to University of Michigan where they have, I'm going to have a different experience, and that's one of the things that this would try to avoid. The integration options, I talked about not going into the technology too deeply, but in case you ever wanted to then do a little Googling after this talk, These are some of the options that you would see out there in the internet. HL7 version 2, version 3, which are based on messages, and I'll show what that looks like in just a second, where things like lab values, demographic information, radiology information might be sent. DICOM messages, which are going to handle ultrasound measurements, imaging measurements in general, actually, and also images. And then things that are meant to make it easier for developers outside the EHR world to do integration work, specifically web services. And so anybody who does web development will be familiar with web service APIs, which means that if you want to use them, you don't have months of learning curve that you would have with the HL7 messages or even DICOM messages, partly because of the way that they're visualized and partly because you just have never used it before, versus the web services. There are two flavors of those in general. There are ones that are specific to the EHR. So in Epic's case, there are many different ways to get information out of their system and into their system via web services, but they're very specific to Epic. And so if you're a developer trying to write a hypertension application to then integrate with both Epic and Cerner, you'd have to do totally different work on the Cerner side to get it to integrate. Versus electronic health record agnostic ones, and I put agnostic in quotes and I'll explain why in a second. FHIR is going to be that agnostic version where you could potentially do the same work and then hook it up into Cerner or into Epic. However, the reality is, I'll just jump over to the cons column for just a second. The reality is that each vendor has different versions of the FHIR spec that they have implemented. Each vendor has different APIs, and each vendor actually can implement different parts of the API. And so there's a lot of investigation that has to go into place on the part of the developer. It's not writing the code, it's not understanding the resource, but it's understanding what the vendor has implemented and whether you're going to get any information back when you make that call. On the pros side, though, it is more human readable, which I'll show you in a second. If you have done web development with APIs and web service calls in the past, you're going to have a much lower barrier to entry for those developers. And so there are charts out there that talk about it taking months to kind of get up to speed on doing HL7 messages versus weeks to get up to speed on using FHIR resources. And then in certain situations, it will be interchangeable and plug and play, depending on the con column that I talked about. And so the most technical slide, I think, in the presentation, at the top, you can see an HL7 version 2 message that gives information about the patient. At the top, you can see the patient's name. This is a screenshot of the internet. This is not real information. And then you have a lot of those pipe delimiters. You can read some of the information there, such as the left knee and left lower extremity, but you have to actually know where to find all that information between all those delimiters in order to know what piece of information means what. Versus in the lower piece, that's going to be a structure that's much more a JSON structure that most people web developers would recognize. And so it just makes it much easier to begin to parse the information to use it or to send it in that particular setting, and then decreases the amount of time that QA takes as well. Finally, a couple real-life considerations in both supporting a learning health system, and I just kind of want to talk about how changes happen in electronic health record. I had kind of informal learning in this as I became a physician builder at University of Michigan and learned about the change control process here. I've had continued informal learning, having worked for several different electronic health record customers and learning more about Epic's internal process. And everybody's a little bit different, which is one of the interesting things. And it gets back to the social part of this. There are cultures in all of these different places for the way that changes happen. And much of it is about the social piece rather than any particular workflow process. And as changes are requested, it behooves folks to understand the social piece of it in order to advocate for the changes that they think need to be made. I know I already mentioned COVID-19 earlier, but I'm going to talk a little bit specifically about some of the changes, quantity of changes that have had to happen in the last couple of weeks. And as I put it together, just thought I would mention that I will do that. So for any electronic health record change in any of the systems where I've worked, people are going to ask several different questions. They probably sound pretty obvious, but such as, why is the change occurring? There is a spectrum there. You could be adding some improvement that doesn't exist at all. or you could actually be fixing a problem. So the user called, the logic isn't what they expected, or an error happened, or a patient care error happened, unfortunately, and the root cause is deemed to be the way that the information was laid out or the way that it was provided to the provider. So trying to figure out what to do to fix that. In addition to that, how does it change workflow? In the work that I do, feel that all of these things really should go back to the user workflow and usability, and making sure that any change we make doesn't cause people to make more mistakes just because we've changed the usability piece. And so figuring out who needs to know about the change if it modifies their workflow. The secondary question within a lot of EHRs is then how do we train for that? In my perfect world, one day the usability would be so good that very little training would have to happen, but the training question is always there. And then what changes need to happen in the EHR versus outside the EHR? So in the COVID-19 example, as the screening recommendations change, there are things within the EPIC EHR at University of Michigan that need to be modified so the documentation is consistent with the screening. But there are also people using paper scripts and who never log into the EHR at all before they get to the person who's logged into the EHR. And so all of that logic needs to match. And so updating that, and if you add an interface on top of that, then you would be potentially adding that you need to change the logic in a third system as well. And so having some feel for what changes and the downstream effects of that. It creates the need for folks on the implementation teams and the EHR teams who have a lot of knowledge in a lot of different areas. But the question then is also asked in the next step, if there is another change, there will always be some that change that needs to happen, whether there is something that breaks or it's in another improvement or the functionality is now defunct. Who is going to own that? Essentially, at its root, who do we assign the incident ticket to so that we can start down the process of fixing it? I've run into that very consistently as the provider physician builder lead now in my role as Associate Chief Medical Information Officer, because physicians don't have as much time as application coordinators to do the changes. And so there's always the question of, if this breaks at 2 o'clock in the morning, who is going to fix it and who's going to own the fixes? So to walk through those three things, why is it changing, who needs to know about it, and who's going to fix it? I just want to walk through in this particular example of the visualization, kind of what the answers were there. So as I mentioned before, the why for implementing this particular visualization was to improve the fact that otherwise providers were having to go to multiple places in and outside the EHR to see all this information in one place, and their current solution was to transcribe it all onto paper. I am not as much an anti-paper person as I am a reduction in wasted workflow time person, because there are certain visual cues that you can get in a piece of paper that have been difficult to implement in other situations. However, it's the transcription and the potential for transcription error, wasted time finding charts. Anybody who's worked in a medical office prior to an EHR will know that as well. So those are the reasons for trying to remove that. The problem was the extra, the additional shadow chart, the potential for transcription errors. You can see in the column for E2 as well, there's some multipliers there, the 1.5x, 2.1x, that's math that's being done by the computer. There are decisions that are made regarding that particular cutoff or that threshold. And if you do the math incorrectly, which is easy for a person to do, then potentially patient decisions would be different. And so the math is done and provided to the provider there as well. On the who needs to know the change, in the infertility clinic, we're the only ones who use those particular charts. So that was pretty easy to know who needed to know what. And the training was pretty minimal because this information the visualization was added to a place where people always went anyway when they were trying to provide care for these patients. And then from a who owns the piece of the process perspective, this is one of the pieces, because I am a provider builder and I coded it, I essentially own this moving forward. And I have a list of things that I own moving forward such that if anything happens, people know who to contact. But that is one of the biggest issues with the provider builder program and having physicians do some work in the system. And it also comes out a lot around the integration questions, because when the logic lives outside the EHR, folks are very curious on, if this breaks, how are we going to make it get it back and make it fixed quickly, especially in the case of things that are used clinically. To reference a few of the EHR changes that have had to happen recently due to the COVID-19 crisis, for those of you who have not heard of them, ICD codes are diagnostic codes. ICD-10 is the most recent version implemented in the US, and they are needed to link things to, you could use them for research, but essentially billing also requires you to have diagnosis codes in order for reimbursement to occur. And then there are procedure codes that are called CPT codes. And so things like the diagnosis code to handle things related to COVID-19 did not exist 3 months ago. It actually just went into effect in March. And the codes to cover the diagnostic testing for COVID-19 also did not exist. And so those needed to be created so that in the workflows, like you would expect, providers can order them and link the diagnosis codes like they do for everything else. Not a lot of training per se had to go into effect. There would be more training about what to do in the time period before the codes exist that you want to exist if you're caring for those patients. And then a quick screenshot of where to find them and what they look like. Makes it pretty easy for folks to find now in the Epic system. Similarly, as everyone knows, without an oversupply of COVID-19 testing supplies, there have been, the University of Michigan specifically, we have moved from sending everything out externally to moving to in-house COVID-19 testing, but that requires a lot of technological changes, essentially so that the provider, the end user, actually doesn't necessarily need to do anything different when they're ordering it, but that it flows to the right places in the computer system so the lab has the right order that they need. And then just as a brief overview of some EHR changes, and there are lots of different ways and permutations this particularly happening, but usually there's some clinical group or clinical individual who comes up with a recommendation for a workflow change rather than an EHR change per se. And then there are policies that get driven off of that. Those are then parsed either by the first committee or in the setting of a second committee where there are really EHR-focused individuals, whether it is purely technical, purely medical, or a combination, physician, nurses, and other, who then say, what do we actually need to change and what would the specifications be that need to change in the system to represent those policies? Lots of conversations about timeline in the setting of COVID-19, lots of conversations about what is the most urgent thing because there are so many changes that it can be challenging to get them all in a timely manner. This is just a software release management cycle, but it is what happens in any change in the EHR. Even when you're doing what I consider configuration and just setting flags or changing labels rather than doing true development. But the things that need to happen, such as creating the specifications, reviewing it, testing it, deploying it, and then supporting it, just continue to happen over and over. And then you can imagine that an incident happens and they figure out that the policy wasn't quite what they meant, and then the specifications change. So it's just one big cycle. And so this is how those changes would potentially get created. From a social perspective, as my time is ending, the biggest question that also gets asked with limited resources is why now? Why is this the particular thing to do next? Those answers often come from those similar committee meetings. So with the COVID-19 crisis, we're actually having daily meetings where we look at everything that's been requested in order to prioritize them to be able to make sure that we're getting things done in a way that supports operations, that supports the providers, that supports the testing, and is done in a maintainable fashion. Because some things can be done really fast, but then changing it later can be very challenging versus doing things that take just a little bit longer to do right the first time and then can be set in place and not have to be changed multiple times over time. So hopefully that gave you an overview of some of the complications with integration and working with EHRs. A lot of it is social. There's the culture of the institution. The culture at University of Michigan, for example, is to try to get everything into Epic that's possible. So that the who owns it question is very, very easily asked. There's the business aspect of that where the licenses then are paid to Epic and you don't have all these additional licenses. And then there are humans and politics involved anytime. And so that gets to the why now question and sometimes asking the right person first something, and kind of getting their approval will grease the wheels in a way that it won't if the wrong person is asked first. And that's just the reality of anything where people are involved. So I appreciate your time. I look forward to the questions after Karandeep's talk, and I'm also happy to answer any questions you know at any time. So thanks very much.
Thank you, Michael. And that was a great presentation. It was really interesting to get kind of a firsthand look at what we're doing here at Michigan Medicine as it relates to the EHR integration and what's involved in that work. So now I'm going to introduce our next speaker, and this is Dr. Karandeep Singh. Dr. Singh is an assistant professor in the Department of Learning, Health Sciences, and Internal Medicine. He's a physician, researcher, and educator interested in studying learning health systems, making new discoveries about disease, and improving patient care through technology. His research areas include natural language processing of clinical notes, risk prediction using high-dimensional data, and mobile health. He is an assistant professor in DLHS and an assistant professor in Division of Nephrology at the University of Michigan Medical School. He teaches a course on applied data science and health to doctoral and master's students. Dr. Singh completed his internal medicine residency at UCLA Medical Center, where he served as chief resident, and a nephrology fellowship at Brigham and Women's Hospital in Boston. He completed his medical education at U of M and holds a master's degree in medical sciences and biomedical informatics in Harvard Medical School. He's board certified in internal medicine, nephrology, and clinical informatics. So now I'm going to turn it over to Dr. Singh to talk about machine learning infrastructure and a learning health system.
Hi, Lisa. Thanks for the introduction. What I wanted to talk through today is really, first, generally at a health system level, what kind of infrastructure do you need to go ahead and actually implement a model? And really to tell this in the form of a story, if you are a model developer, someone who's kind of got interest in developing or implementing these kind of risk prediction models, what's the kind of challenges that you're going to face? And what are the kind of 7 good habits of implementing machine learning models that you should put in place as you go from an idea with a model that you want to implement to something that's actually in your system and working with a workflow around it. So the first question I want to start with is, why machine learning at all? And then as I get into some of the specific use cases, I'll actually get into how we're handling some of these questions at Michigan Medicine right now. So the first question I think on everyone's mind is always, why machine learning at all? Isn't machine learning overhyped? Isn't there a lot of buzz around it? But what are you actually trying to do when you say you want to implement a machine learning algorithm? And many times it's someone on a quality improvement committee who's trying to do something, and someone suggests some kind of a model to inform what they're doing, and it always the question comes up, well, what would the model help us with? And I think in general, the purpose of any kind of, whether it's a machine learning model or a predictive model, is to help you prioritize patients. In general, it's taking a patient, a set of variables about them, a set of predictors, trying to map those predictors onto the probability of them having some kind of an outcome, whether that's deterioration in health, some kind of complication, readmission, and then sometimes it's simply enough knowing who the high-risk patients are to be able to deliver some kind of care to them that you previously couldn't. So an example of this is that, let's say you've got a hospitalized patient with a rising heart rate and a dropping blood pressure. The nurses are occupied. There's physicians are tending to other patients. That patient is in their room by themselves. And sure, there may be someone monitoring the cardiac monitor, but how do you bring that patient to the attention of someone who can check in on them and make sure they're okay? A model running continuously in the hospital, for example, can help you identify such patients and then figure out some workflow around that where you can help those patients. Another thing a model can help you do is prioritize interventions. So, patient comes into the ER is flooded with patients, and a lot of folks are being seen. Many of those patients come through triage, and triage's job is to figure out who needs to be seen first. Well, if triage gets overwhelmed, or if someone came in okay and gets sicker when they're in the emergency room, A model can help you figure out, who is the most high-risk patient, however you decide to define risk, and use that as a way to, have providers see those patients first. So a way to prioritize interventions. And lastly, if you think of supply as being limited, which it usually is in reality, a model can help you allocate resources more efficiently. So just imagine a scenario, such a model doesn't really exist in any kind of reliable fashion. But let's say we had a model that could estimate, the patient level transmissibility of a virus like the flu or like COVID-19. If we had a limited supply of personal protective equipment or masks, we could potentially use the model to help us figure out if that was the only objective we had was to limit the spread, help us figure out, how to allocate those masks to the right patients in the setting of limited supplies. So it can't help you figure out what the right strategy is, but if you have, a set of constraints, it can help you figure out where to focus your energies. And the truth is that there's already been a lot of work happening at Michigan Medicine and University of Michigan more broadly around machine learning and health. And so, this thing on the right is just a survey we completed with a series of kind of key stakeholders. And we identified, easily over 30 projects focused on machine learning that were already underway. And this is in no means, a comprehensive list. So let's say you're a model developer and you've got an idea for a model. How do you take that model, in Ann Arbor, Michigan, from an idea to something that's actually running in the hospital? So from the perspective of a model developer, these are some of the things that they commonly think about. They may have developed a model in one data set, and they'll want to know in your electronic health record, does the model that they have developed, when they implement it, is it going to have access to the things it needs? So if your model relies on a highly specific test or some kind of imaging that is not linked in our system, then obviously it doesn't matter how good the model is, it's not even feasible to take that model and put it in our system. The other thing they'll want to know about, or that they may want to sell to you as they're trying to pitch the model to you, is to say, our model has really good discrimination. And what discrimination means in this context is, can the model differentiate a patient who's high risk from a patient who's low risk at all kind of levels of risk? So this is a relative determination. Take two patients from the data set, can your model successfully say, that's the higher risk patient? And if it can do that most of the time, then that is a model that can discriminate and identify those high risk patients successfully. The other thing that they might want to look at is, or might want to pitch to you, is their model calibrated? So they have a model that predicts, the chance that a patient is going to go to the ICU. That seems like a pretty important thing to try to intervene on. So if they say my model has says there's a 5% chance this patient is going to the ICU, is it actually 5%? Is it 2%? Or is it 20%? You can have a model that's not calibrated well that still can relatively, say who's higher risk than the other one, but none of the predictions themselves are any good. And another thing from a model developer standpoint is they may use one data set to develop a model, and then they say, I want to implement this at a different system. So let me see how well it works in systems where the model wasn't developed. And they call that external validation. And so they may be really excited to share with you, as someone who's on the clinical side or on the operations side, we've got this model that's been externally validated. So it should be good to, put in your system if this is a model that you need. So what's the next thing that they would do? So I'll just say, as we talk about these 7 habits, the 0th habit is basically, you need to start with a useful model. If you don't have a useful model that can tell apart, sick patients from less sick patients, there's really no need, or there's really no benefit from trying to put that model into clinical practice, because it's pretty much a non-starter that the model's not doing what it's supposed to do. So these are the types of graphs that a model developer might put together. The left one showing that it's got great discrimination, great sensitivity and specificity at specific thresholds, and the right one showing that, hey, when the model says you're at 40% risk of having an outcome, you're actually at 40% risk. But as people know who are on this, on this webinar, and anyone who's interfaced with the health system, discrimination and calibration are almost like the least of your concerns. The challenges of implementing any kind of a machine learning model in a health system is fraught with challenges that go well beyond, can you get these graphs looking pretty, and is your model actually useful? So let's say, you've got, you're a model developer and you say, well, I'm going to do this the right way. And you don't have clinical expertise, so you reach out to a series of clinicians and try to identify a problem. So you're very much early in the stage of developing your model. The first habit really is that you should think about selecting a treatable problem. And what I mean by treatable problem is, this is a problem where physicians can agree both on the definition of the problem and on the right course of action. And at least if you look in the literature, it seems like sepsis is potentially this type of a problem. I think it's true that, the definitions of sepsis aren't completely agreed upon. But in terms of the right course of action, I mean, most clinicians would, at least if you ask them, would agree that, yes, if someone has sepsis, we should probably give them antibiotics. We should probably give them IV fluids. We should probably draw blood cultures. So I think, none of that is really that debatable from a standpoint of what is the right thing to do. And there's all kinds of publications out there on models that try to predict onset of sepsis for patients who are either in the hospital or in the intensive care unit. So is sepsis a treatable problem? And some of this comes back to this issue around the definition. So there's actually two definitions of sepsis. The first definition is this consensus sepsis 3 definition that basically tries to identify perfect cases of sepsis. So they meet all the various criteria for sepsis, and retrospectively, when you look back at these patients, everyone can agree, yes, these patients definitively had sepsis. On the other hand, when health systems are kind of being measured on their ability to care for patients with sepsis, they're subject to these SEP1 quality measure that is designed by Medicare. This measure is often assessed on patients who get billed for sepsis. And so if you're building a predictive model or a machine learning model to try to predict who's got sepsis, the question is, are you trying to predict actual perfect by the book sepsis, or are you trying to predict patients who have been billed for sepsis? And while you would think this is like relatively high degree of overlap, there's a fair number of patients who meet one of those criteria and not the other. So maybe the problem you should be trying to solve is, why don't those criteria match? Because ideally they should match. But this just goes to show you that if you try to predict the consensus definition of sepsis, but your hospital is judged on its ability to care for patients who've been billed for sepsis, even with the perfect model and great interventions designed around it, your measures that you're actually reporting out to the world, how you're assessed in your ability to care for sepsis patients, may not be any better. So just the first challenge, I think, is how do you pick that right outcome and make sure it's a treatable thing that everyone agrees upon and has a consistent definition. So do physicians actually agree on the right course of action? Sepsis, I think, is an interesting example because it's so much on the minds of health systems right now, not just ours, but health systems around the country. At Stanford, they implemented a decision support alerting system for sepsis. And they actually figured that when they randomized patients to this kind of an alerting system, where it's not powered by a machine learning model, but it's powered by a set of decision rule logic that's running continuously in the background, similar to the way a model might run in the background. They thought that they would probably make some difference in some outcome. And so they looked at, does it make people get antibiotics sooner? Does it improve mortality? Does it improve length of stay? Does it improve our ability to transfer patients to the ICU? And does it improve our ability to give patients fluids? Well, it turns out in a randomized controlled trial setting, a model that was developed to alert patients to the onset of severe sepsis did none of those things. So none of the primary outcomes or secondary outcomes were met when this kind of a system was put in place by Downing and colleagues at Stanford. And interestingly, when they asked people, well, why didn't you give fluids? Like that's like in the guidelines. It says give this much fluid. And only 2 out of the 26 physicians who are participating actually gave the right amount of fluids. The physicians said that, many of them were worried clinically about those cases, or they felt like, the patients weren't sick enough to warrant fluids. And some of them just disagreed with the guidelines. So this just goes to show you that even if you could bring the right patients to the attention to the right clinicians at the right time, if the physicians don't truly agree that that's the right course of action most of the time, all this work is not going to lead to better health. So the idea is for you to be able to actually improve health, you've got to be able to, change what happens at the bedside, at least in the setting of healthcare. So now that I've told you that, that intervention just didn't work at all, none of the primary outcomes improved, none of the, secondary outcomes improved, you'll be pleased to know that the, quality committee at Stanford looked at this and said, yeah, let's just not roll this. Actually, no, they actually rolled this out to all the patients in the whole hospital. So this goes to show you that even though they've got evidence that this doesn't work, once you get onto this path of using information and data to support decision-making, even when that decision-making doesn't change, it's very hard to go back. And so at Stanford, although you would think the rational thing would have been based on those numbers to kind of stop this and say, it's not working, what actually ended up happening was that this was expanded to all patients because of the overwhelming benefit that was qualitatively felt by the quality committee. So what's our approach to sepsis at Michigan Medicine? So we actually do have a sepsis prediction model implemented. We have a model that has been running for several months. It used to run every 20 minutes on all hospitalized patients. It currently runs every 15 minutes on all hospitalized patients. On certain hospital units, if you have a risk score that crosses a specific threshold, the electronic health record generates a page to the nurse to go check on that patient. The nurse does a secondary assessment. They calculate a score, they look at the patient, and if the nurse confirms that the patient is at high risk, then there's actually a page that gets sent to the first contact, who in most cases is either a physician or a physician's assistant. So that's been implemented for quite a while now. We're still looking to see, is that system actually working as intended? Is it improving clinical outcomes in the way that we'd like? At the same time, that system is being expanded to more units. But how do we get here? How do we get to a standpoint where we've got this thing running in the system? And certainly there was a lot of work that was done by the hospitals and the health systems, sepsis committees and other infectious disease committees. But what about this model? How does that actually work at Michigan Medicine? So identifying the right mechanism to support these kinds of machine learning or predictive modeling efforts at Michigan Medicine has been a challenge. It's not just a challenge here, it's a challenge at every health system around the country because of the kind of complexity, not just of getting these models to work, but to be able to design workflows around them. We've historically always had a committee for quite a while now focused on clinical decision support alerts. So, some of the alerts that Michael Lanham was referring to are things that, interrupt a provider when they're seeing a patient while they're in the chart to be able to say, hey, you may want to do this. But when it comes to these kinds of early warning systems or machine learning models that are running, on a continuous basis on a fixed set of patients, many of these things need to run even when there is no provider logged into that patient's chart. They need to be running on an ongoing basis. And so we didn't really have a great mechanism to take that concept and have a room of people be able to facilitate moving these kinds of things forward into our health system. We had, I think a couple attempts have been made. There was an attempt, which some of you may be familiar with, called the Predictive Analytics and Surveillance Subcommittee, which was kind of designed to look at some of these things. But it's a tough nut to crack. And so I think that didn't really work out in the first iteration. And then in July of 2018, the Michigan Medicine Clinical Intelligence Committee was formed. And this was another kind of go around to support these efforts operationally. And so in principle, I put both of those committees up there, the Decision Support Committee and the Clinical Intelligence Committee, because in essence, these are sister committees where they kind of handle related types of issues, where the Clinical Intelligence Committee is focusing more on those kinds of models that use, either machine learning or some kind of predictive modeling to guide decision making. If you're a researcher with an idea, you might start on the left side of implementation and go out to some of our fantastic research groups on campus that do predictive modeling in the health domain, which includes MyChamp, the AI Lab in the College of Engineering, and the Michigan Data Science Initiative. Then you may want to, operationalize or try to pilot some of this stuff in a healthcare setting. And we've got a great, colleagues in precision health implementation at the University of Michigan, led by Haimi Cho, who's really been helping researchers come with an idea, get connected with the appropriate people, and then advance the idea to a point where things have been clinically validated, the model has been mathematically validated, and then it comes to the Clinical Intelligence Committee to think about how to take something like that, not just the model, but the entire kind of workflow around it, and endorse it to go forward or to help develop the idea further, to make sure that it's going to work in practice and not just as a numerical exercise. So if you look at the things that I said early on, is what does machine learning let you do that we think are really high value things? The vision of our CIC is basically to support those three things that we kind of laid out. So the vision of CIC is to enhance the quality of care and improve health outcomes through model-driven interventions, recognizing that it's not just a model that's going to improve something. There's got to be an intervention linked to it to get the better health and better health care, to identify at-risk patients sooner, and then to kind of make care more efficient and increase patient satisfaction. So make sure the care is patient-centered and efficient, so that we can care for the most number of patients possible. This is a group on campus that in the Michigan Medicine that has a lot of different stakeholders as part of it. I'm mainly showing you this just to kind of put a human touch on kind of some of the work that we're doing. So we've got colleagues from physician informatics, nursing informatics, pathology informatics. So those are the folks that work with kind of all the lab data that comes through our system, which is particularly of relevance right now. Our health information and technology services team, who know kind of what's possible and how to make these models be able to interface with end users in a productive way. And then folks from quality and learning health systems and quality analytics to really help us prioritize what are the quality issues that we need to be tackling, so that the work that's happening related to machine learning is not happening in a vacuum, but is really linked and directly designed to support ongoing efforts to improve quality at Michigan Medicine. We start off with a few basic questions around, is your idea originating from, or your request coming from an operations request? Is it a research request? We try to have, folks who are requesting this think about what is the problem they're actually trying to solve and why would using a model help solve this problem. Many folks who come to us already have a model in mind, like they came across something in a publication or they heard about something that's implemented or available. So we kind of try to get that out of the way. Is there something you've got in mind? Let us know. And then really a lot of the work that we do is around that fourth question, which is what is the intervention or workflow that's going to enable things to actually get better in terms of clinical care, assuming that the model is any good. So assuming you've gotten to this point and the model is good, how can we capitalize on that and actually use it to improve patient care? So the second habit to be able to do this kind of work is that you need infrastructure and resources. And so imagine this scene in an academic medical center, and you've got this researcher who comes to you and says, we built a sepsis model, we want to pilot it. Historically, and very commonly across the US, if you've got a very savvy IT department that wants to help out, or a research IT department, they'll say, we'll build a web interface to your server. So you run all the logic, we'll build a connection that goes to your computer, and great, now everything's connected. You're able to run your model on our patients, and we're able to get that data into our system. So now another researcher comes along and says, we want to pilot a no-show prediction model. We want to know who's going to not show up in clinic. So then, they're a separate researcher with their own IT setup. And so, your helpful hospital IT says, yeah, let's build another web interface to you too. So you can have it too, you can have it too. And then, of course, there's the intermission where the new electronic health record update gets installed. And then, researcher number 25 says, wait, why is my model not working? And the idea here is that when you're building all these separate interfaces, it's like you're using, a series of canoes to cross the river rather than having a bridge. So on the technical side, you need a way to have one kind of main way of handling this kind of traffic, this kind of logic, so that when things are being updated, you're able to test to make sure things don't break in anticipation of new updates happening, rather than these separate interfaces where you can't actually easily test all of them at once. So on the technical side, there's a lot of solutions to this problem, but you need to be able to manage the entire life cycle of machine learning models, not just that implementation. So you need to be able to store models, you need to be able to map variables to models, and that variables probably live in your electronic health record. So there's got to be some very tight interface there. And you've got to be able to manage versions. So you update your model, your logic's got to update. And so, how do you, continuously update your model as needed, rather than kind of have the same model in place for years. One example of this is Knowledge Grid, which is developed in our department under the leadership of Chuck Friedman and Alan Flynn. But there are several other options available, and one of the options we have is a electronic health record vendor-based cloud platform for running predictive models in the cloud. So specifically, we've got this infrastructure running. Infrastructure comes with a set of models that we can deploy. But one of the really cool things is that we actually can run any machine learning model in the cloud as long as that model runs in Python. And so getting back to one of Michael's points, you want to give developers a language and a toolkit they understand and are best suited for. So by separating out the logic in which machine learning models need to run, which most models are developed in some kind of an analytical language like Python, and letting the folks who work in our health IT department work with a set of tools they're familiar with to do the connecting up of the models to the logic to the electronic health record system, we're actually able to have kind of the best of both worlds with everyone working in the environments in which they're comfortable. And so basically lowering the barrier to getting these kinds of models implemented at Michigan Medicine. You also need to solve a lot of issues on the social side. And so some of the key ones are around governance. So who's going to be the one putting in the requests? So who brings forward these ideas to our attention? We have been pretty clear that if a model developer brings something to our attention, they need to have a clinical champion actually involved. And it's that clinical champion who really needs to explain to us how this model is going to be used to improve practice. It's not a model developer who's going to come in and kind of wow the room with their statistics without kind of that clinical person there clearly explaining what the entire workflow looks like. In general, though, other governance issues historically have been who approves these models. And if you're going to have a bunch of requests coming in, who prioritizes them? Does each update of the model need reapproval? So let's say you're just changing a coefficient. Does that have to go back through reapproval? In many instances, historically, the answer would be yes. And I think we're currently in the process of thinking through this to make sure that we're providing the right degree of oversight and not too much and not too little. Who evaluates whether the models work? Is it the model developer who's kind of pitching the model to you, or is it your quality department who understands how the model is affecting or being able to interface with quality measures? And what happens if the model goes awry? So imagine a situation where we've got a sepsis model and it goes rogue and in the middle of the night, starts paging every provider. What's going to happen there? So our committee is basically tasked with evaluating these issues. So in order to have a governance, you have to have a reporting structure. And so recently, we've gotten a change where we're now officially on the kind of organization's map for being able to report up to our IT operations and management group. I'll highlight kind of one or two other points, and then I think I'm going to skip a series of slides in the interest of time. So I'll just say that, from the model developer standpoint, they always think about internal and external validation. Like, I made my model here, I tested it elsewhere, and that must mean it's going to work at, the next place. But I'll say that when you're sitting at an organization like Michigan Medicine, doesn't really matter that much that the model worked at 3 other places. We, recently had this experience where a model worked great at 3 other places. We turned it on here, ran it in the background where, it was kind of running silently, and the model didn't work here. And so, we don't really care about internal, external validation. When you're sitting in the health system, you really care about local validation. Does it work here? Because if it doesn't work here, it's not going to be of any use. The other one I think is just to think about, one question that often comes up is, how is this different than a best practice alert or a decision support alert? And I think the overall difference is that there's a lot of different ways that output from a model can be operationalized in order to actually link it to some intervention. So one of the ones that I think is really, really common here that isn't as common kind of in the usual normal decision support alert setup is page. So for high-risk patients, where no one's in the room, where we've got information coming in from their vital signs, we have systems up and running right now that will generate pages. Another one I would say is being able to sort patients by acuity is something that you don't think about in a kind of traditional decision support alert mechanism. But when you've got to prioritize patients because you've got more patients that you can handle than you can handle right at the moment, right now, a model can sometimes be very helpful to help you make some of those tough decisions on how to assign priority. But one of the things I'll kind of close with, and then I'll kind of go towards the end, is how would you operationalize something like a clinic no-show model? I kind of alluded to the fact that there was a researcher who developed that. Now, you might use it to double book patients. So you're predicting that one of these 2 patients is not going to show up. So let's just double book them. And then the question becomes, what happens if they both come? This is not the airline industry where we're going to, pay patients to stay home because, we accidentally overbooked. You would probably have to see them. And there's a question around, is that going to be fair and is that going to be sustainable? We could call those patients who are high risk of canceling and say, do you want to cancel? But the problem is that the high risk patients, who are high risk of canceling are some of our most vulnerable patients. So that may not be really the ethical way to handle output from this kind of a model. Finally, we could say, let's arrange for transportation if you're high risk, because maybe you're high risk because you don't have transportation. So this just shows you that how you take the information and use it to, either facilitate or impede care can really have downstream effects that can affect the most vulnerable patients among us. And so we have to be very careful that just because you can prioritize doesn't mean all prioritization is the same. So I think with that, I'm going to, kind of just jump to the end here and say that, a lot of people to thank for this. One of the things I covered in the end is that, and I alluded to this, is that you can do all this work and then the model and the intervention might not work, despite the fact that you had a good model. So there's a lot of challenges along the way. I think we have a system in place now and some infrastructure and governance and technology at Michigan Medicine to be able to take these ideas, move them along, and get them into clinical practice in a way that I think we historically have been challenged. And I really look forward to engaging with the broader research community around challenges that we're going to face in this space. So thank you so much. And Lisa, I'll turn it back over to you.
Okay, great. Thank you very much, Karandeep, for sharing everything that you've been working on here and the activities of the Clinical Intelligence Committee. I want to remind participants that they can enter questions through our Q&A section in the live stream. And we already have some questions queued up. And I think, Michael, since you went first, I'm going to start with you. And there's a question here that says, does SMART, and maybe you want to also remind people what SMART is. So does SMART solve some of the problems you've described with FHIR? As I understand it, SMART is intended to make an external app work with any EHR that is SMART enabled.
So, sorry. So SMART, and I apologize, I'm actually Googling it to be able to give you what it actually stands for, and I should have put it in my presentation, is essentially just the login piece. It is nothing more than that. And so it happened that SMART and FHIR, SMART was working at one piece and basically then used the FHIR resources to define the specification. But if you think back to the slide that I showed where there was the Facebook login and that particular thing, that is that functionality is the SMART piece. So you can have a FHIR application that does all the different work, that you have a different login, or you can make it a SMART on FHIR application and you use the login that's provided by either the EHR or the patient portal. Those would be kind of the two options. It's a great mnemonic because both FHIR and SMART are great mnemonics because everybody's heard them and there's a lot of hype about them. But at its base, the SMART doesn't fix any of those things. It is pretty consistent. It's such a small piece to implement that the login piece should not be particularly complicated to move from one vendor, one Epic customer to another, although there is some code to change the client ID. Or to move from one vendor to another. So the login piece is not as complicated, but unfortunately it doesn't fix any of the other pieces.
Okay, great, thank you. Another question also for you, for learning health systems, appropriately getting structured and unstructured data out of many EHRs into registries and data pipelines is a priority. What initial uses of FHIR bulk data are of most interest to learning health systems and why?
It's a very interesting question. I think it's going to be very dependent on which pieces of the learning health system want to take advantage of it first. Because one of the things I didn't mention is the FHIR specification has been changing over time and is finally at the point that there are some what are called normative resources which will no longer change in a way that a developer would have to do programming changes if modifications were made. And to this point, they've all been drafts such that they could change it, that would break software. The bulk data is all still in draft, is my understanding. And so I'm kind of going around the question so much because it's going to depend on the use case, really. What models like what Karandeep was talking about would potentially be able to take advantage of that. And that's what's going to drive which pieces of that is actually going to drive which pieces of it the vendors create first. Because the specifications are always bigger than what the vendors can turn out immediately, it's the customer use cases that drive them to say, yes, we will develop this piece of the specification first, and we will mature it at this speed. It adds a delay because the specification changes, and then it's 6 to 18 months before Epic turns out their Epic or Cerner turns out their version of it, another 6 months before it's actually installed at any particular customer. It will be helpful. There have been projects I've been on that trying to even query, I want the set of patients who have this diagnosis or have this particular prescription. With the way that the FHIR resources work now, it's not usable. So that bulk data and that sort of bulk search option will be very helpful for getting there, but I don't know which pieces of it will be used first.
Okay, thank you very much. I'm going to move on to a couple questions for you, Karandeep, and I think I have actually a two-parter here for you. So the first part is, in the implementation research world, there's a lot of discussion of integrated implementation, building in tests of implementation issues, including workflow issues. What would it take to get predictive modelers to work collaboratively with implementation researchers and QI folks to think these issues through?
Yeah, so I think that's a really great question. And I think it actually is broader than just predictive modeling and predictive modelers. I think it's true for all health IT-based interventions, not only at Michigan Medicine, but across the country. To study EHR-based interventions, you need to have a implementation framework around being able to do those. And so an example of what I mean by that is, it's very naive to think that you can just randomize patients at a patient level and study these kinds of interventions, because there is so much interplay between the different parts of the workforce that there's really no way to do this properly at a patient level. You have to think about other levels at which you could do this kind of work, and it's a pretty big undertaking and a little bit at odds sometimes with operational priorities to be able to get these things implemented. So I think it's something that we're striving to do. I've been trying to put together, and with colleagues of mine in the department, think about putting together a implementation framework for some of the common types of ways we operationalize models, to think about how we may study them. But I think that's a cultural shift that we have to make, is that rather than thinking about pilot here, go to another unit, and then go to the entire health system, to really think from the very beginning about how can this be studied at the same time that it's being implemented in a methodical way. We absolutely need help from our implementation research colleagues, and I've engaged some of them to try to help with this. But I think it's a cultural, structural issue, almost more so than it is anything specific to a predictive model. It's just as true if you implement a decision support alert in our system. We don't have a great way, as of right now, or what I would say a low-hanging fruit way of going from that idea to having a full-blown study to evaluate it.
Okay, how about simulation? Is there a role for simulation and testing out some of these models?
Yeah, so I think the word simulation gets used a couple different ways. And when it comes to modeling, I think it's really a very hot topic right now, because it's pretty much impossible to build models right now that are machine learning models or predictive models to predict various things like when we're going to run out of masks, or when we're going to need more blood in the blood bank, simply because we're operating under such unusual circumstances that we don't have a such thing as data to train a model on, such that we could run such a model. So in those kinds of settings where you just don't have the data, you've really got to model based on assumptions. And so I think a lot of the things that are in the news around this is the number of ventilators we're going to need, or the number of masks we're going to need, are really built around simulation models of some sort. Some of those are epidemiology or oriented. Others come from others, like supply chain or other parts of the people with different types of expertise. But I think I would say, are we equipped to look at that? We're not directly equipped to look at it right now, but I am, along with Michael and others, involved in some of the broad modeling efforts, or at least on a basis to try to contribute to that discussion as we figure out how to incorporate that information into planning for the organization.
Okay, excellent. Thank you very much. I think I have a couple questions. I'm going to switch back to Michael here. And Michael, these questions have to do with your comments in your presentation around the vendor APIs. And the first one here is, how do you currently deal with proprietary vendor APIs to ensure reuse of previously written machine interface integrations?
Not entirely sure. I'm going to try to answer the question. So there are a couple different resources that I'm aware of for Epic, and I would expect they exist for Cerner. So some that where essentially you pay, if you are a vendor, you pay Epic and you get support, and then you also get access to information about their APIs. So you could look at what they've written for Fire, see if what you've written against should exist. And then they also have, I apologize if there's background noise. As you all know, we're all working from home, and I have a 3-year-old and a 16-month-old. So that's probably what you're hearing if you're getting it now. They have documentation on what exists, and they also have a sandbox. So you can plug your application into their sandbox and see if it works and run testing that way. There is also open.epic.com that is meant to have a subset of those APIs, all Fire APIs that are then learnable essentially to the outside world, including a sandbox there. So for Epic, those exist. And I believe that at least the open piece, kind of the sandbox piece, exists for Cerner. I know it does for the CDS hooks, which is all Fire-based. And so those would be asking the vendor. I would essentially just ask the vendor, really would be my first step. How do I do this? Because they're going to be able to answer it pretty quickly.
Okay, great. The next question, again, has to do with the proprietary vendor Fire and related APIs. Do you foresee in the future the ONC requiring health IT vendor API testing and certification?
I have been, I would say that's kind of out of scope for what I focus on personally. One of the cool things about my consulting work is I'm very much in the trenches doing the development and work very much with the internal teams. It is part of my goal professionally to continue to kind of learn about that in a way that I could answer that question better, but I don't know.
Okay. One more question for you, and then I'll take one last look through the chat and see if we can squeeze one more in. But how do you think SMART on Fire, CDS hooks, and the LHS department should intersect? And what solutions do you see for population health management, for example, SMART bulk fire?
So I think that my answer is partly to address the social political piece. I think that we should find a project that has some good visibility, works very easily into a workflow that would alleviate some problems for folks, and that they can understand things like a knowledge object or a knowledge grid pretty seamlessly. And I think we've identified a couple of those. For example, there's a particular gynecology surgery post-risk calculator that has been developed by the OB-GYN department that could potentially be used to modify recommendations from a gynecologist to a patient on what type of route they should have for their surgery in order to reduce risk after the surgery. So because it has the potential to be patient-facing, for the provider to then document back into Epic pretty seamlessly without having to type an additional note, and it is parallel to a workflow that they're using for patients who have had a previous C-section and would like to attempt a vaginal birth, and they already have a workflow where they go outside the system, then redocument back in the system. It kind of, in my opinion, ticks a lot of boxes. I think that something small like that also helps with kind of proof of concept and getting the right people to understand how it will be changed over time. Because like I mentioned, any change then has to be understood. There's the change management cycle around that, making sure that it works. And so I think things like that will be important. And then also, if it doesn't involve any technology that's soon going to be turned off. So one of the things I noticed in Karandeep's presentation was that paging functionality, which is great, except that Michigan is moving to unified clinical communications in the fall, which actually will mean no one has pagers. So all of those pieces then have to be redesigned, and things like going out and finding a list of everywhere we're currently paging to make sure that to figure out what we're going to break and fix that ahead of time. And that type of project doesn't have it. So doing something that's contained enough would be a good first step, I think. Okay,
very good. Well, I think I'm going to make the decision to bring our session today to closure. I want to thank our two speakers again. Dr. Lanham and Dr. Singh, thank you so much for your presentations today. And thank you everybody who joined us on this live stream. And thank you for continuing your interest in the LHS Collaboratory. And please keep checking our website for future updates on additional events. And thank you all very much.